All right, the digestive system. Chapter 18 in your anatomy book. I'm starting on page 492. I always like teaching the digestive system. I always find that it's the easiest for me. Maybe you'll feel the same way. And the reason I feel that is that we're very familiar with our digestive system. We are familiar with the names of the parts that belong to that. Like we know our intestines and our stomach and our liver. Like we've heard these organs. There's a lot of diseases that go along with it that we may, you may have personal knowledge of, things like ulcers and diverticulitis. These are very, very, very common. So maybe you or a family member may have experience with some of these diseases. And so I find that the digestive system is very easy for us to relate to. Okay. So let's get into it. Okay. So the chapter, like most chapters, kind of start out with an overview, kind of a highlights, and then we're going to get into all of the organs and then, of course, the diseases as well. So the digestive system is responsible for three functions. Digestion. It has to process the food that we eat. Then it has to absorb from that food that we ate. It has to pull the vitamins out, the carbs, which are our energy, the protein for our muscles, and unfortunately, the fat that it likes to hold on to as well if we're giving it a lot of fat, which is the delicious food, right? And then metabolism. We take all of that stuff and we have to metabolize it, which means we're going to convert it from food to becoming part of our body in the various ways that it needs to be used. It doesn't say it here, but the fourth function of the digestive system is elimination. All of the stuff it didn't want, we're going to get rid of by process of elimination. Okay. The structure of the digestive system is a very long tubular structure, with the only part that really isn't a tube is the stomach, and the tube kind of goes right through the stomach. So I always think of the stomach as just kind of a big fat tube with that one part. And that's called the alimentary canal. It's also known as the GI tract, gastrointestinal tract, and it's also called the digestive tract. So it has a lot of names, and it all means the same thing. And it is a straight through tubular structure from opening in the mouth to the exit in the anal canal. And we know that it's a long tubular structure. If you've had a child, you may remember when you've changed a diaper and they've had peas or corn, and the shell of the pea or the corn wasn't digested by the child, and you find that shell coming out into the diaper. And as we age, of course, our body learns how to digest that shell, and it doesn't continue, but you kind of know it's a straight shot through. You also see that sometimes on TV shows when they talk about, like, you swallowed a marble or something, how it comes out in the other end. Okay. Just a couple again to start the chapter, kind of some overviews. We're going to get into these topics much further as we get into it, but we talk about the topic here of chemical and mechanical digestion. So when we take the food that we eat, obviously, whatever our bite is, it has to be broken down. And there's two ways that it does that. First of all is a mechanical digestion, means that something is physically breaking it down, and that mechanical digestion starts with our teeth. As we chew it, we're breaking it from the bite to something smaller that we can swallow. That mechanical digestion continues in our stomach. Chemical digestion also begins in our mouth, because the saliva that combines with that food, those food chunks that we're chewing up, the saliva starts digesting food as well. And then, of course, we have acid when we get into the stomach, as well as some other chemicals that are part of the system. We'll get into that much further in depth later in the chapter. This is just kind of your overview. So before we get into each of the organs one by one, I want to talk about the walls of the digestive tract. And there are 4 layers to the digestive tract. with the exception of the stomach. The stomach has only 3, but we'll get there when we get to the stomach. But all the rest of it has these 4 layers. And we have the mucosa on the very inside. Then we have the submucosa, muscularis, and the serosa, okay, from the inside to the outside. So the inside is the part you can touch, like the inside of your mouth. I don't want to say you can touch the inside of your esophagus, but if we put a scope down there, we can look. So that mucosa has to be kind of tough because all the food that we swallow rubs against it. And sometimes we swallow things that are a little scratchy, like potato chips or something, if you didn't necessarily chew it up good enough. And sometimes you swallow, you're like, oh my gosh, that scratched my throat as it went down. You can kind of feel it. So that mucosa has to be tough and to be able to withstand that. The submucosa, which is the next layer, and I'm actually going to scroll into the text here rather than use the picture. Your submucosa is your blood vessel layers. Okay. The muscularis is exactly what it sounds like. It's the muscle layer. And we need a muscle layer because the muscle, when it contracts, it is going to stimulate the process called peristalsis. And peristalsis is defined as rhythmic, wave-like contractions. And so what happens is when it contracts and that tubular structure squeezes down, it pushes the food along. So I think of the digestive tract when I teach it as a big tube of toothpaste where you squeeze here and it moves the toothpaste along, and then we squeeze here and it moves the toothpaste, and we squeeze here and here and here. And that's peristalsis. It's a wave of contractions and it moves the food along. And you've got that picture here where you've got the contraction. This is called a bolus. Bolus is the ball of food you swallow. So you've chewed it up and you're ready to swallow whatever your bite was. And so it's not really a ball because it's like all these individual particles, but that's what a bolus is. It's that clump that you swallow. Okay, and so we have the contraction and it moves the bolus along, and then it contracts again, moves it, contracts again, and moves it. Okay. That's peristalsis. And then the last layer of the digestive tract, which is the innermost layer, is called the serosa. And that is your connective tissue, which helps connect it to the structures on the inside. All right, so we're going to start with your alimentary canal, and we're going to go from entrance to exit, and we're going to hit some of the organs that attach on as we go. So the first one is your mouth. It's where the entrance is. It's where we take a bite. Your mouth or your oral cavity. We have 2 palates. We have the hard palate and the soft palate. When you feel the roof of your mouth, the hard palate is exactly that. It's the hard part, which has bone on the other side, which is the very roof of your mouth if you stick your tongue up there. But if you stick your tongue further to the back, eventually it runs out of bone and it's soft and squishy. That's your soft palate. Okay. Both of those palates are keeping food separated from the nasal cavity. Okay, we've got that divider. Okay. Then at the back of our mouth, we have the uvula, which is the little piece that hangs down. That uvula actually triggers to keep the food to go down the throat rather than up into the nasal cavity. Because we all know that it's connected back there because you can breathe in from your mouth or your nose and the air gets to the same place. And so if the food were to go upward, that would be bad. That uvula also comes into play really important if you vomit. We need to make sure the vomit comes back out the mouth instead of up into the nasal cavity as well. So that's your uvula. The frenulum is this piece right here, and it attaches your tongue to the bottom of your mouth, okay? And sometimes you could have a baby that is born with a very short uvula, and it's too short. That would be a condition we call tongue-tied, and you might have to go in and cut it. Just do a little snip right there and cut it just a little bit to give that tongue a little more movement. depending on how severe that is, that could prevent a baby from being able to suck, a bottle or breastfeed, which obviously is a big problem. That would be a very urgent surgery that we go in and fix that. Other times it's less severe, so we don't need it so early. But then as that baby grows and we realize that frenulum is causing speech problems, and so we don't know that until that baby's talking, which is of course much later in life. Okay. Then we have the teeth. You do not need to know the different kinds of teeth, but we have incisors, canines, premolars, and molars. And you don't need to know your numbers, but you can see that the child jaw has less teeth than in the adult. Also, you can see here is where they talk about how old the baby is or the child is when they show up, okay? And then we have the molars here that show up even later in life. Like you have another set of molars that show up like around age 12. And then the last set of molars, which we call wisdom teeth, are typically more 15, 16, 17 years old where they show up. And some of us, they don't ever come through. They just kind of stay under the gums. Those teeth were really important historically in evolution. If you think back to caveman days, you would imagine that people don't keep their teeth their whole life. And so by the time they're 12, they probably have some teeth that they've lost. And great, here's some new molars that show up around that age. And guess what? 15, 16, 17, here's another set of molars. And of course, life expectancy wasn't that long. And so it got them through their life. Of course, with improved dental care, you and I may never have a tooth lost from disease. And so nowadays, a lot of people don't have room for their wisdom teeth because you still have all of the teeth that you were supposed to have. And it messes up our teeth, or it comes in and there isn't room for it, or you might need to have them surgically removed. Okay. And we talk about the term mastication, which means to chew your food. So go masticate your dinner tonight. You can use that word at dinner and impress your family. Okay. All right, your teeth. I just want you to know a couple of terms here. The crown is the part of the tooth you can see. So it's the part that sticks up over the gum. That is made up of a material called dentin, and which is covered by enamel. So the enamel is the part you see. And then if the enamel gets eroded, you might see the dentin, okay? But the crown is the whole part that you see. And then the root is the part under the gums that you don't see. Okay. That's pretty much all the parts of the teeth that you need to know. There's some other things there, certainly great information, but you don't need to memorize it. Okay, so our salivary glands. We have a couple different spots where they are in our body. So you can see the parotid is up here in the cheek. The submandibular, mandible means jaw, so the submandibular is kind of under the jaw. Sublingual, linguo means tongue, so it's like directly here. Okay, so you got them here, you got them here, you got them up here. Okay, so that kind of sits there with a whole bunch of saliva. You can see that it says your body secretes about 1 liter of saliva every day. So I think of a 2 liter of soda, half of that. That's how much saliva we make in a day. That's a lot. Okay. But we constantly have moisture in our mouth. Okay. And we're constantly swallowing it too. Okay. The parotid is the largest of our glands, our salivary glands. And the saliva secretes what's called salivary amylase. Amylase is an enzyme that breaks down carbs. And so that's part of that chemical digestion that happens right there when we first put our food in our mouth. I also have a little note here off to the side. ASE is the medical term suffix for enzyme. So anytime you see a word that ends in ASE, you know it's an enzyme. Later in the chapter, we talk about lipase, we talk about protease, Lipase is for fat, protease is for protein, and those are enzymes as well because they end in the ASE. So you always know when you see that it's an enzyme. Okay. The one disease we really talk about with salivary glands is mumps, and it's a viral disease, which of course most of us, I would imagine, are vaccinated as part of our MMR vaccine, that we've never experienced mumps. Our children have never had mumps. Probably most of our parents have never had mumps because of the vaccinations. But it's a swelling of that parotid salivary glands, which typically happens in children. However, it can be more severe if an adult gets it. And your MMR actually is your measles, mumps, rubella vaccination all in one. One of the concerns with mumps back when it was a very common disease is that about 25% of men, the inflammation actually also goes down into the testicles. When that happens, the men could be rendered sterile. So that was a big problem 100.5 years ago, whenever it was they came up with the vaccination. Okay. So some of the other diseases we have of the mouth here. First one is mouth cancer. Mouth cancer is tied to chewless tobacco. So like your chewing tobacco that you kind of stick in the side of your mouth, and it just kind of like sits there in your cheek, and that can be can lead to these white patches called leukoplakia. Leuko meaning white. Leukoplakia, which then can turn into cancerous tumors. Okay, it typically is between your gum and your cheek, right where the here where it's talking about the snuff dipper's pouch, where you put that wad of tobacco, can turn into cancer. You can see that's probably not a very good area because what if we have to do surgery and remove it? We're talking now plastic surgery because it's going to completely mess up your mouth and your whole face. Okay. Dental caries, C-A-R-I-E-S, that's tooth decay. So if you've ever had a cavity filled, that is called a dental carie. Okay, so most of us are familiar with dental caries, maybe not the word, but what it is. Thrush is also known as oral candidiasis. That is a basically a yeast infection of the mouth. We've got a picture here of it. Okay, it's a common condition of babies that, and it's very hard to cure once they get it. All right, and then the next two diseases are congenital, meaning you were born that way. We have cleft lip and cleft palate. What it means is that the structures for the lip, the upper lip, or the roof of the mouth did not form properly while the baby was a fetus inside their mama's belly, and there are openings where they don't belong. Some of these openings, especially the one in the palate, may cause sucking problems, because when a baby sucks, either a bottle or breastfeeding, there is a seal around what it's sucking. Well, if the hole in the roof of the mouth is creating that lack of a seal, that could cause that baby to have a problem latching on and eating or drinking from their bottle or breastfeeding. And obviously that's a problem. The lip one typically doesn't cause issues with that. I mean, it can, but typically it doesn't. These are both things that can be surgically fixed. With the cleft lip, they tend to wait till the baby's a little older, 2 or 3, before they do surgery, but they can certainly do it later. Well, it says 1 in the book. Okay. All right. So we've taken our bite, we've chewed it up, we've mixed it with some spit, and we're ready to swallow it. And I called that structure that you swallow, I called it a bolus. Okay. And now here we are. We swallow, and the food now goes to the pharynx. If you were here last module, this structure should be a familiar word to you because the pharynx is both part of the respiratory and the digestive system, meaning that the pharynx carries food and air. Okay, it's at the very back of the throat where the nose also comes down, and we swallow food as well as breathe the air. And really, the pharynx is just a tube that everything goes through. That's it. It's got those 4 layers, the mucosa, submucosa, muscularis, peristalsis is happening and moving that food along. Now, at the end of the pharynx is where the food has to go one way and the air goes a different way. So our food goes into the esophagus. The esophagus is another structure with those 4 layers, that mucosa, submucosa, muscularis, and serosa. It is about 25 centimeters long or 10 inches, and all it does is it connects the pharynx to the stomach and the food goes through it. That's it. Okay. However, at the top and bottom of this structure, we have a sphincter, and a sphincter simply means a round muscle, donut-shaped muscle. And because it's a muscle, it can contract and it can squeeze and it can close completely. Okay. So we have an upper esophageal sphincter and a lower esophageal sphincter. So if this is our esophagus, we've got one here and we've got one here. So when we're breathing, this sphincter is closed because we don't want the air to go into the esophagus. The esophagus is for food, not for air. So it closes off. But when you swallow food, it's going to relax and open and let the food in. Likewise, the lower esophageal sphincter is going to open and let the food into the stomach. But once the food is in the stomach, we want it to close back up and not let the food back up. A lot of adults have problems with that lower esophageal sphincter where it doesn't close completely. And what will happen is that the food will kind of start messing with the bottom of the esophagus and kind of hanging out there where it's not supposed to be. And it's not so much the food that's the problem, it's the acid from the stomach. And the acid burns. It's called heartburn. And if this is a chronic problem, it is actually called GERD, gastroesophageal reflux disease. And that is a chronic acid reflux feeling that a lot of adults suffer from. The next disease we talk about with the esophagus is called a hiatal hernia. So I'm going to talk about this picture first, and then we'll go to the next one. So the esophagus comes down, and this is a diaphragm. This is a muscle that goes across our belly. It's our breathing muscle, and there's a hole in it to let the esophagus through with the food, just like it's supposed to be. The other side of the diaphragm is the stomach. So the food comes through the hole in the diaphragm and then it goes right into the stomach. Okay, great. That's how it's supposed to happen. However, sometimes the upper part of the stomach pulls to be on top of the diaphragm. So our stomach actually ends up getting squeezed here where it's not supposed to. And that's called a hiatal hernia. Now, we have lots of kinds of hernias in our body that we can have. Hiatal means it's always this esophagus problem. Okay, so if I just tell you the patient has a hernia, you don't know what kind. It could be one of the other kinds that isn't here. But the hiatal is always here. Okay, because the inguinal is in the groin. You could have an abdominal one, but the hiatal is always here. Okay. All right, the stomach. The stomach has 3 parts. We have the fundus up here. We have the pylorus, which is down here. And then the body is the rest of it. The esophagus comes in and drops the food. Notice how the fundus is above where the esophagus joins. The fundus typically doesn't get a lot of food up there. unless you eat Thanksgiving dinner and you put a lot of food in your belly. And then so much is entering the stomach that it actually goes above the line. Okay, so when you can't breathe after that Thanksgiving meal because you had to have the second helping and the pie, you couldn't wait, 2 hours for the pie, you had to have it right away, and you're just feeling very, very, very full, that means that your fundus is full. Okay. The body, you can see, has 3 layers of muscle here. Okay. So it still has the mucosa and the submucosa and the serosa that we've already been talking about. But with this one, the muscularis has 3 layers of muscle. Okay. There's a lot of action going on here in our stomach because our stomach is actually going to churn the food, and that's the part of the mechanical digestion. So the mechanical digestion started with our teeth chewing, and now here in our stomach it's churning. Okay, that's the second part of the mechanical digestion. Those are the only 2. There's only 2 kinds of mechanical. And those 3 layers of muscle are what's doing it. You don't need to memorize the names of the layers, but you do need to know there are 3 layers of muscularis in the stomach. And then the pylorus is the exit. So when our stomach has churned it and we've got the acid going on, so we got chemical and mechanical digestion going on, and that food has turned into a slushy mess, it's ready to now go into the intestines. Okay, because we can't put big chunks of food into the intestines. We have to get that down into that slushy mixture. That slushy mixture is called chyme, C-H-Y-M-E. Okay, chyme, and that's the fluid makeup that's now going to go into the intestines. Okay. The pylorus there has a sphincter, remember, is a muscle that's shaped like a donut and can squeeze off. So as we're digesting, that sphincter is closed. We are not letting food into the intestines until it is turned into that chyme mixture. Okay, so the sphincter is closed up until it's ready to open. Okay. Okay, that's it for that screen. We will scroll, and we're going to now get into diseases of the stomach. So some of these we're certainly familiar with. Nausea, which then can turn into vomiting. We've all, I'm sure, experienced that. Nausea is just the unpleasant feeling that often leads to vomiting. Sometimes it just stays at that nausea, and other times you vomit, and and you're like, thank you for vomiting because now I feel better. Anorexia, I really don't like this definition. It literally means chronic loss of appetite. Yes, people who are anorexic stop feeling hungry, but anorexia is more of a mental disorder because they won't eat because of the fear of becoming fat. So there's a whole different psychological component to the word anorexia, where I don't think that definition says enough. Gastritis is just inflammation of the stomach, which could be from a variety of reasons. Okay. All right, pyloric stenosis is that pyloric part of the stomach, that exit, might be too narrow. And sometimes pyloric stenosis has to be surgically corrected. If you have pyloric stenosis, you were born that way. So if you've got an infant where the food can't really get out of the stomach good enough, my nephew had this, and at about the age of 1.5, he was closer to 1, had to have this surgically corrected to open up his pyloric opening because it was a problem. Okay, ulcers, big problem with adults in America. 1 in 10 American adults will have some kind of an ulcer in their lifetime. Some of them are small and minor, and others are much more serious. They do find that ulcers are a result of having this H. pylori bacteria in the belly. H stands for the Helicobacter pylori. You'll see that both the full word as well as the H. pylori when we do coding for ulcers. Ulcers can be much more serious. They can be bleeding ulcers, which can then put blood into the intestines, or if you vomit, there's blood in that too. Okay. All right, stomach cancer is linked to excessive alcohol consumption, chewing tobacco because some of that tobacco juice gets swallowed, or eating smoked or heavily preserved foods can lead to that as well. Couple of terms here with diagnostic procedures. The upper GI, upper gastrointestinal is an X-ray study. With an upper GI, we're doing the stomach upward, okay? And the patient would then swallow a liquid called barium sulfate. We just call it a barium swallow. And then that barium will actually kind of glow upon X-ray. And you can see the picture here of kind of how it looks. And that's the stomach you're looking at. So you can see the body, you can see the fundus at the top, and you can see the pylorus and the pyloric sphincter coming out that bottom part. You can see that pretty well in that picture. All right, the next structure, we've now swallowed the food, we've digested it through our stomach, and now it's hit our intestines. Your intestines have two parts. You have small intestines and large intestines. Small intestines are named because of the diameter of the tube, because the diameter is smaller than the diameter in the large intestine. These are not to scale. However, the small intestine is much longer than the large intestine. So when they say small intestine, don't think length, because the small intestine is all bunched in there, kind of going back and forth like this, like a big long spaghetti tube or spaghetti noodle, just kind of all in there in a designed way. They're not just kind of shoved in there. And there are three parts: duodenum, jejunum, ileum. You need to know them in that order. Whatever it takes to remember that those three parts of the small intestines go D, J, I. Duodenum, jejunum, ileum. Sometimes you'll hear the word pronounced duodenum. Both pronunciations are actually acceptable. I just like duodenum better. How do I remember the order? This may not work for you, but I have a nephew named DJ, and so I just kind of think of him and then go I is the last one, because DJ goes together and he comes first. So DJI is kind of how I remember it, is I think of him. So come up with a little phrase or saying or something. If that helps you, come up with something that the D and the J and the I can stand for. Okay. More chemical digestion happens here in the first region of the small intestines, which is the duodenum. Okay. Because the duodenum is now where other enzymes are added to the chyme. Remember, the chyme is the slushy mixture that leaves the stomach. And so we have fluid now coming in from the liver and the pancreas at this point. Okay. All right. Also in our small intestines, we have these structures called villi and microvilli. So our intestines, you think of it as a tube, but it's not really. That tube has ups and downs like this on it. So while it is tubular, it's not straight. And the reason why it has all of that is it increases the surface area. There is more tissue that chyme is going to pass along. And that tissue is what's absorbing the good stuff out of the food that we ate. All those vitamins and minerals and proteins and carbs and all those things that we need is being absorbed here in the small intestines. And so by having increased surface area, there is more tissue that is available to absorb the good stuff. Okay? So these these ups and downs are called your villi. And think of, the book uses those as called like fingers. And then the microvilli, I'm going to switch to a pencil here. Let me give a red one. The microvilli are little, almost hair-like, that comes off of all of those. Guess what? It's even more surface area available for absorbing all the good stuff that you ate. Okay, so the villi are the big ones, and the microvilli are the tiny little ones. Okay. So what can go wrong now with our intestines? Well, it can all get inflamed, called enteritis or gastroenteritis. Med term, your small intestines is entero. So anytime you see entero, that means intestines. Okay? So gastroenteritis is inflammation of the stomach and intestines. Enteritis is just inflammation of the intestines. So we can have problems. Maybe you eat great, you eat all the right vitamins and minerals, but your body is having a hard time absorbing it. Here in the small intestines, it's called malabsorption, means that you're giving the body what it needs, but it can't absorb it. Those villi and microvilli are just not doing it for some reason. And so you can end up being anorexic, you can end up being anemic, you can have all these vitamin disorders because you are not absorbing the good stuff that you ate. Okay. I'm going to go ahead and stop the video here, and I'll start with video 2. We'll pick up exactly here where we left off and continue and finish the chapter with video 2.